Hi everyone, I think we can now start the meeting. So I'm glad to open the Tuesday meeting of VODAN Africa and Asia. So welcome everyone to this weekly session. Today, as you can see on the slide, the agenda is planned with a lot of things. So the first thing is we will start with Dr. Arai's presentation on Ethiopia digital health ecosystem analysis, and then we'll go to the loop of updates. So basically there are updates from access and control group, and then CEDAR localization group, and then the template, dashboards, and also we are going to have a round of updates from country coordinators, and then update on the special issue, and then questions and answers. I hope we can stay on the given time. So with this one, I would like to give the floor to Dr. Araya in order to present his slides for today's meeting. So Dr. Araya, the floor is yours.
Yeah, thank you, Alia. Can I share my slide?
Yes, sure, you are already co-host.
Yeah. Can you see my slide? Hello?
Yes, we can see
Hello.
it.
Yeah. So thank you for the opportunity. I will talk about Ethiopia digital health ecosystem. It's like a quick analysis, quick review, and I will have a summary at the end. So my presentation will talk about the available policy documents we have for Ethiopia in relation to health information system and digital health. And I will talk on the current status and policy gaps. And recently, the Federal Ministry of Health Ethiopia is working on a digital health blueprint for the next 10 years. So I will talk why digital health blueprint is needed and the building blocks and enablers, as well as prioritize the digital health interventions in this working document or digital health blueprint. In Ethiopia, we have several policy documents in related to digital health or health information exchange. Since 2010, 2011, the country has been trying to have guidelines, manuals for health information exchange. And as a result, there has been impressive progress or progress with implementation of health information system in the country. And we have, at least we, together with Gato, Samson, we have been analyzing available policy documents. We were able to identify about 15 health information related documents and policy manuals. And what we have learned from our desk review of policy documents is that Ethiopia has adopted almost like WHO guidelines, policy documents, and also other countries' experience. And looking to the Ethiopian digital health related policy documents, we can say that in relation to VODAN and FAIR initiatives, the policy document advocate for making data accessible, findable, interoperable, and reusable. The challenge, I would say, is that the how part is not well documented. How we can implement these FAIR principles or other health information systems related global goods or global guidelines in the Ethiopia context. Otherwise, I don't see we have a big gap in policy document or policy direction. Rather, when we look to the different national documents we have, there is an overlap or duplication of documents. I mean, we have several documents, but they can be summarized, or we could have one overarching or guiding policy document. The gaps that we have identified or we observe in the Ethiopian digital health related policy document is that one, the documents we have or the policy manuals we have, they are several and heavy policy documents. And probably I would say that some of the policy documents are more than 100 pages, and implementers, stakeholders may have difficulty to get or to catch up the main instance of the document. So for a brief and palatable policy document, guiding document for stakeholders is necessary. The focus so far with the Ethiopian digital health policy document is on health information exchange. There is less attention given to future trend or emerging technology. So focus is needed to address the rapidly changing digital health as well as the health system itself. So addressing or embracing emerging technologies is necessary. However, in the policy documents, the emerging technologies like artificial intelligence, like autonomous vehicles or use of drones is not well touched in the policy document. And another challenge, much of the policy documents we have are dependent on the WHO guidelines, which is good. However, it has its own downside that in-country experience or wisdom from Ethiopia are not included or are not well touched in the policy document. And this is partly because we don't have much implementation or scaled implementation of digital health in Ethiopia. Another point worth mentioning in the analysis of policy documents in Ethiopia that although Ethiopian health policy advocate for a decentralized or federated approach, however, in the digital health, in real practice, the policy write-up, policy making is deeply centralized, and this has to be noted and corrected. So to address these policy gaps, the Federal Ministry of Health of Ethiopia is working on a new overarching or guiding document that is named as a digital health blueprint. I will come to this digital health blueprint later on, but with the current status in relation to Ethiopian digital health is that recently there has been an assessment, health information system maturity model assessment for Ethiopia. And based on this maturity model assessment, the digital health implementation in Ethiopia is categorized between the levels of emerging and the established. I will come to this, what I mean by these levels of emerging and established. And the other is, if we look currently or recently, WHO advocates for a smart guideline for evaluation or guiding of digital health implementation in this era. And based on that smart guideline, it has 5 layers. And we don't have assessment made based on this smart guideline, but my judgment based on this smart guideline, I would say Ethiopian digital health implementation status or current status can be labeled as paper-based or traditional guidelines, layer 1 of the stage or according to the smart guideline. What I mean by maturity model assessment, hello? So based on the, I think WHO and other organization, in particular the measure and the evaluation group advocate for this five-stage maturity level assessment in digital health implementation or health information system. And based on this maturity assessment, it has 5 stages. The first stage is nascent, emerging, established, and institutionalized and optimized. And when I say Ethiopia is between emerging and established levels. This is a recent evaluation for the Ethiopian digital health maturity status. And according to the maturity model assessment, there are 5 components. These components are like leadership and governance, management and workforce, information and communications technology, standard and interoperability, and data quality and use. Based on these 5 components of the maturity model assessment, the Ethiopian digital health status is lies between between the second level, which is emerging, to the level of 3, which is established. As you can see from this slide, for the health information system management and workforce, the country's maturity level is measured or categorized as 3.27. And this rating is made from out of 5. Each component is ranked or scaled out of 5. So we are between 2 and 3 based on this assessment. And this assessment is made by the Federal Ministry of Health. Hopefully, as many of you have may know about the SMART guideline, WHO guideline, Professor Miriam shared us a few weeks ago about this guideline. And this SMART guideline, by SMART, we mean like standard-based, machine readable, adaptive, requirement-based, and testable. And this new guideline has like 5 layers from level 1 to level 5. And this is a description, explanation of these 5 levels. Like level 1 is for enhanced guideline, traditional guideline, and level 5 to precision model. As I mentioned earlier, we didn't assess the Ethiopia digital health implementation status based on this new guideline, but in my own experience and my own judgment, I would say Ethiopia digital health current status lies on the layer 1, traditional guideline. Maybe there has been some initiatives that tried to have a guideline for specific services like maternal and newborn services, but this has never been materialized. So I would say Ethiopia is still on the layer 1. So to benefit from digital technologies and digital health innovation, the country needs an accelerated implementation of digital health. So considering these different global initiatives and the country need to accelerate implementation of digital health, the country is working on digital health blueprint. And the reason for digital health blueprint is one, to have a simplified overarching guiding document, because in the analysis I mentioned that there are several policy documents, but they are heavy and there is an overlap, and they are not simplified. So with the intention of having a transition from e-health era to digital health era, the country needs an overarching guiding policy document on digital health. And this is almost finalized, and this digital health blueprint will be launched by next June. That is the plan of the Federal Ministry of Health. But once it is launched, I would be very happy to take this VODAN platform to share the details of the digital health blueprint. The second need is to have a forward-looking document, policy document, and to embrace the emerging technology. And with this digital health blueprint, the country wants to embrace or to enhance public-private partnership. And one point I would like to mention that one of a recent opportunity in Ethiopia for digital health is that the government of Ethiopia has issued Digital Ethiopia 2025 strategy. This is not specific to health, it is for the whole country. So the current government of Ethiopia is aspiring to realize the vision mission highlighted in Digital Ethiopia 2025 country strategy document. These are some of the guiding principles highlighted or written in the digital health blueprint. I will not go into the details in the interest of time. And and this one is the conceptual framework or the framework that is being adopted in the digital health blueprint, in the new guiding and overarching document. And in this framework, the Ministry of Health is advocating for 4 building blocks and pillars. These 4 pillars are access and delivery, solution and services, ICT, and data hub. And not only the 4 building blocks, but also the Ministry of Health has identified 5 enablers like governance and leadership, workforce, research and innovation, security, system security, standard and interoperability. And this framework, Digital Health Blueprint framework, is adopted from the WHO WHO and ITU e-health strategy toolkit. This is the WHO advocating to have an effective digital health countrywide implementation. WHO is advocating for these 7 enablers or to create a conducive digital health environment. We have to work on leadership and governance, and we have to have a strategy and investment, workforce, legislation, service and application, standard and interoperability, and infrastructure. So yeah, we can see the Ethiopian health system is adopting global guidelines and standards. As a priority, of course, this is also related to WHO recommendations of digital health intervention. However, the prioritized digital health intervention for Ethiopia are somehow customized and adapted with the country Digital Ethiopia 2025 strategy document, because in that national document, there are priorities. And the Ministry of Health has tried to align these priorities with the health policy and the health sector transformation plan of the country. And the Ministry of Health, together with the stakeholders, in the digital health blueprint, about 10 priorities are identified, like digital performance management, remote healthcare delivery, decision making support, digital health payment, data exchange across systems, point of care, unique digital ID, digital literacy, digital health entrepreneurship. Especially, you know, Ethiopia is a country of 110 million population, and there is a boom, young population, and there is high rate of unemployment. So the Federal Ministry of Health wants to use this emerging potential of digital health for creating jobs, and also to see the health as part of the economy sectors. And of course, we need centers of excellence for digital health. In summary, I would say there is huge enthusiasm and interest for digital health at a country level, and the policy documents or the digital health ecosystem of Ethiopia has a great tendency of adopting global goods, standards, and guidelines. I don't think we have major problems of adopting what WHO is dictating through the SMART guideline or through the WHO digital health intervention recommendation. So there, we would say that from policy perspective, although we may not find the term fair or other abbreviations in the policy documents, but literally the interest of making data accessible findable or reusable, interoperable, or using standards is part and parcel of the digital health policy in Ethiopia. However, in the Ethiopian digital health ecosystem, or in general in the country, there are fundamental structural bottlenecks for creating a conducive digital health ecosystem. One, in Ethiopia, we have only one government telecom service provider. We don't have private telecom service providers. And this creates a huge problem for innovation, for demand-based digital health testing and the implementation. So liberalization of the Ethiopian telecom service from the point of digital health is really key. However, it is highly monopolized, government owned, and we don't have private telecom service providers. Second, low trust and opaque health system. As I mentioned earlier, the Ethiopian health system advocates for decentralized health system. However, when it comes to digital health, I mean, because of ignorance or because of fear or lack of knowledge, there is low trust from the health system side to digital innovation or to partnership on that. And this has to be, improved. And this could be for other countries as well. Most of the policy documents we have or digital health strategies we have are mission oriented. They are not market oriented. Of course, this has to do with the health system because the main service provider is government and it's not as such for a market. However, we have to see health as an industry, health as a market. And if we can open the health system for innovators, for entrepreneurs, and if our priorities are set based on the market, and this will flourish the opportunity for digital health. However, it's mission oriented, I would say. The other, we have poor private sector engagement. This is related with government or donor-driven initiatives. The contribution of private sector in actual digital health implementation in the country is low. And last point I would mention is that there is a strong hesitancy to dive to implementation and learn. There is a kind of paralyzing fear of failure. Probably much of the initiatives we have are government owned and they are donor sponsored. So they don't want to take a high risk of failure. However, digital health implementation should be owned by the entrepreneurs, the innovators within the country, and we have to have flexibility for diving to implementation and learn. And I think for a good success, we have to have a strong support for innovators, entrepreneurs, and leaders who would like to take the risk and learn from actual implementation in the country. Thank you so much.
Thank you very much, Dr. Araya, for this wonderful presentation, which is very informative for all of us. Is there any question related to this presentation or to Dr. Araya? So there are no questions. If not, I think we can proceed to the next point. Thanks a lot, Dr. Araya, again. So with this, I would like to give the floor to Putu. Oh, sorry, just a quick update. So I would like to ask all advanced genetics article authors to send the approval to Professor Miriam from your official email addresses. If possible, also put your ORCID number. I'll send to the chat the ORCID registration link, so you can register in ORCID and also send your ORCID number if possible. Thanks. With this one, I would like to give the floor to Putu. So please go ahead, Putu.
Thanks, Alia. I will share our progress in access and control. I will share my screen. Can I share my screen, Alia?
Yes, you're already co-host.
Yes, thank you, Alia. So yesterday, as always, we had a meeting with the each coordinator and also with Professor Miriam. And first, I want to update short update about the communication with health facilities. Uh, so the overview is from Uganda's side. So Mariam will contact the hospital that is still no response to her email. And from Kenya, Kenya has a plan to meet Nairobi Metropolitan Services Ministry of Health, and one of the hospital, it is a Beacon of Hope, give the data steward name, so it is a really good progress. And from Somalia, already introduced a facilities communicator to 5 health facilities that agreed ready to go with this project, and now waiting for the last approval to start the project. And from Tanzania, I just got the data processing agreement from Dr. Jeremia. So I forwarded to Professor Francisca. And from Ethiopia, all health facilities have been contacted and 20 data steward assigned. From Ethiopia team, they send the short checklist about the health facilities to gain information about data stewards. And now we have 20 data steward information. And from Nigeria, 2 more health facilities expected soon in a week. So it is MI Wushishi Primary Health Care and Arc Medic. And the last report is from Zimbabwe, booked to meet the Provincial Health Information Officer for access to facilities. So that's the overview of update health communication. From the access and control discussion, so Mariam was present about the information flow within hospitals in Uganda. This is the important presentation because the steps of this research is quite same with our project. So this is really good to like an example to follow the process of this research. So several questions arise from that presentation. I will make it short because we have not a lot of time. First question is, this is really related to our project. So first question is, the finding was, so from Mariam's conclusion, there is a conclusion that the finding was a data accessibility problem. So for whom it wasn't accessible, so is it patient data and should be confident, because patient data should be confidential. So I want to make it clear, because the accessibility means here is not to make patient data online and can be accessed by everyone, not like that, or the subject or the stakeholder that need the data, not like that, but the accessibility means the analytics carried out on the data by Ministry of Health only accessible to Ministry of Health. So the VODAN project is to make that kind of data is also accessible for health facilities, and also from the outsiders, such as the researcher, the health, the data scientists. So that's the idea of VODAN project. So the second question is, this is for Miriam, but I will summary for that. Have you checked which part of the information flow are going to be disrupted or changed by our minimal viable products? So get to ask about this. So which part of information flow? So if we connect this to our project, so which part of information flow in the health facilities that will be going to disrupted or changed by our minimum viable products? So the answer is, the VODAN Africa project works by creating one-stop data entry that allows health facilities to analyze their data and input them to HMIS. So basically, the project will not impact most of the information flow. So they will do their procedure as business as usual from the health facilities, but we will make the patient data recorded and also it is machine readable, and also provide their data analytics, and automatically input that to HMIS. So basically that's the idea of the project. And the next question is, who selected as interviewee in Mariam work? Will this project use the same question list from Mariam Basaja's work? If I connect this to the project, so the interviewee is data management personnel, so the H coordinator should seek for the data management personnel, or the person that involved in data entry and getting the data to put in the system. So basically, this kind of person is involving in data governance in health facilities. And for the Foreign Africa project, we will use a different question topic list. I think I already state that I created a topic list that can be found in this link, bit.ly/Fodan interview tools. And it's not a fixed topic list, because each coordinator should adapt to that communication topic list. I just give the general communication topic list, but each coordinator should adapt to that question if they think that it's necessary to add some questions there. So and the last question is, oh, wait a minute. And the last question is, do we have the legal ground to replace the current system in health facilities? So basically, we will not replace the procedure. We will not change any procedure in health facilities. But we want to demonstrate that machine readable data has many advantages. For example, just like I said, that they have their own data, so they not only Ministry of Health can access the data, but they can also access the data, and also has their own data analytics. And also the researcher and data scientists could access the data, but with access and control procedure. So and however, the project should our project should concern with the health facilities that already digitize the data flow procedure. For example, in Tanzania, the doctor directly input the patient record to the computer. So the digitization is like ahead from the other health facilities. So we should concern about that case. So that's all. And the next, our next step is to discuss agreement draft with health facilities, and also communication topic list discussion that will be adapted by each coordinator. That will be the next step for access and control team, Alia. Thanks. So back to you, Alia.
Thank you very much, Putu, for this wonderful update. So let me share again the screen. So with this, I would like to proceed to the next point, which is update from the yesterday's CEDAR localization meeting. Basically, yesterday we have discussed an updates on the templates, basically the vocabularies that we create. So every country technical coordinators were asked to fill out the Excel sheet. So I will send it to the chat. So make sure that you fill out this one. So this is the Excel sheet every country coordinator has to fill out. So please make sure that the terms are added in the sheet that you want to reuse from bioportal, and also the terms that you would like to create. So then we'll make the common list of vocabularies in order to reuse it within the VODAN group. So that's basically the main update from the yesterday's CEDAR localization meeting. Regarding the template group, so last week we didn't have the training of data stewards, so that's why there is nothing to add. I just would like to remind everyone that this week, Thursday at 3 p.m. Central European time, we'll have a meeting of the training of data stewards. So please plan your time beforehand. The next point that we are going to have an update on the dashboards. Dr. Sakinat, would you like to give an update on this one?
Thank you, Aliyah. Hello, hi everyone. Now the update on the dashboard creation is that we have taken a new turn now, and we have actually put it in 2 different groups, and we expect that because this was just done recently, and Professor Miriam gave a lowdown of it yesterday. So I propose that you give us time to put ourselves together, because I still have to have meeting with Rudwan and Yilin, because they are going to take a very prominent role in the dashboard and in the dashboard creation. And we are yet to finalize some things with Getu and Samson. So I implore us to give us a little time to put ourselves together and come and give a comprehensive report to the House. Thank you.
Thank you, Dr. Sakinat, for this update. So during this week, we'll have another meeting on the dashboard creation. So together with John and all the technical members on the dashboard creation. So I guess another more significant update will come next week, because we will identify what do we have and what we will do as further steps. I see that Professor Francesca, yeah, she says in the chat box, so that we had also discussed about the mock implementation. So this week we are going to have also mock implementation of CEDAR embeddable editor, also with the ONTO portal, in order to see that we have all the components to go live. I hope next week we'll have more like the complete update. So, and basically going to the next point, I would like to ask country coordinators to give an update on the communication and on the status of the state of the art, please. I would like to start from Wondimo. Wondimo, can you give us an update? So Wondimo is not on the call, I see. Okay, let me check if Din Jamal is here on the call. So I don't see him as well. Dr. Reginald, please, can you give us an update on the communication?
Yeah, thank you, Aliyah. Yesterday we managed to send the letter of introduction to Nairobi Metropolitan Services, Ministry of Health, and also a sample agreement for them to study. Then today we are expecting them to respond to us. We're supposed to have had a meeting, but then they were locked in another emergency meeting. So I expect a reply perhaps tomorrow or the day after. I know that in the group, the same group, we have Dr. Asma, who is also a member of this group. So they are looking at the issue. So perhaps by Thursday, I'll have a more definite response from them. Thank you.
Thanks a lot, Dr. Reginald, for this update. I see the message from Kuda that he says Professor Bernard is on the another meeting. So let me ask if Dr. Jeremy is here. So I don't see Dr. Jeremy in the call. So I think we can ask Dr. Sakinat then. Dr. Sakinat.
Yeah, thank you, Aliyah. Hello, everyone again. Considering the reports on our country as per the hospitals, right now, Nigeria have close to 20 hospitals that are willing and ready to partake in our project. But we are kicking off with 6 of the hospitals that are ready. And I'm sure that the documentation that we need is on its way. We are preparing Professor Mijam to promise to give us a document, like an agreement between us and the hospital. So right now we could say that we are good to go. Thank you. Unless Kawu have anything to add to what I've just said.
No, I think I don't have anything to add. You are on point. We're all set to go. 6 facilities are earmarked to begin with. Thank you.
Thank you, Dr. Sakinat and Abdullahi Kawu for this update. So I think Putu can also catch up with other country coordinators later on after this meeting, so in order to see the state of the art. So with this one, I would like to propose to move to the next point on the special issue. So Misha, please can you give us an update on the special issue?
Yeah. Hello. For the special issue, it is going very well. Shall I share my screen? Or so with regards to the first special issue that is going to be published, all the articles have been sent to Susan. Which is excellent, and which means that we're well on track to have them all edited by very soon, and so that is excellent. We received Article 8 and 15 back from her, completely edited, and we've also received one new article, which we've named Article 37, and which is about African digital health, an emerging narrative.
Hello, Misha, we can't see your screen.
Like this?
Yeah, we see it.
Yeah, okay. So we've also received Article 37 by Geert-Jan van Stam as a submission for a new article. It's I was talking about African digital health, an emerging narrative. So as you can see from the spreadsheet, the vast majority of articles are bright yellow, bright green, and most of the dark green ones are almost finished with editing, which means that we're really almost done with the first special issue. And as you can see here, all the articles for one have been sent to Susan. So so that's excellent. Are there any questions?
Misha, I have a question. Article number 12, I think I have sent.
Yeah. We haven't really determined which article, which special issue that's going to be in, but I was about to send it to Susan.
Okay, thanks.
So we're sending all the ones that are definitely an article in the first special issue, so that they are pushed forward, and then I'll send that one. Yeah. Any other questions? No.
Well, I see there are no questions.
Okay, thank you very much.
Thank you, Misha, for this update. So I think we have covered all the points that we planned for today. Oh, Misha, there is a question. What is the timeline for the issue to be out?
I don't have a specific timeline that has been established, but I know we are in contact with I know we're in contact with the publishers, so I'll try and give you an update on that by next week.
Thank you. Thanks a lot. Are there any more questions? I see that Wandimur has raised his hand. Yeah?
Hello, Alia. Sorry, I have a connection problem and I couldn't provide update from Ethiopia. I think already Tigist posted the in chat box. So we have completed the requirement for the CEDAR implementation. And FRM submit all the required document to PUTU. So now we are waiting to discuss on the administrative plan with Prof. Miriam, maybe today or tomorrow, and then we will finalize the action plan for the implementation of CEDAR. So this is a brief update from my side. Thank you. Over.
Thanks a lot, Wandimur. So yeah, thanks for this update. And I also see there is an update from Tigist on the same issue. So thank you, everyone. Let me ask if there are more questions related to any points that we have discussed today. So if yes, I would like to close the meeting for today. Thank you everyone for joining this meeting, and I wish you a wonderful and fruitful week. Yeah, thank you, and have a nice week.
Bye.
Bye, everyone.
Bye, everyone.
Bye.